I'm really delighted to be able to introduce our next speaker, Dr. Gillian Leng, who is in charge of NHS Evidence. She works in NICE, the National Institute for Clinical Excellence, which is a body that I consider to be extremely precious, and to shine a bit of a light, not only in the UK, but potentially around the world, in terms of how one can evaluate the cost effectiveness of interventions in a way that allows for rational decision making at the local and government level. Now, NICE is an institution which is constantly in need of support from those like-minded, right-thinking people, and I'm sure that Gillian will convince you of that if you aren't already convinced of it. And she's going to talk specifically about NHS Evidence, which is a new initiative in the UK to provide, I note in the programme it says comprehensive twice, which must mean it's comprehensive, service for health and social care. Over to you, Gillian.
Thanks very much for that introduction. Yes, a very comprehensive service I'm about to tell you about. It's called NHS Evidence, but just to emphasise at the outset, because I know you're not all from the UK, it is largely available internationally through the internet. It also is somewhat of a misnomer, because we cover not just the health service, we cover social care too, which you'll see from the title. So in the next sort of 40 minutes-ish, I'm going to cover briefly where we are now in terms of NICE and NHS Evidence within it, talk about some of the new developments, and highlight some future opportunities that might be coming our way. And knowing that you're a very knowledgeable audience, I'll focus on some of the more tricky issues rather than simply saying this is what we do, because it's not all that straightforward. There are lots of methods and processes that we are still working through, and I'd welcome your input on some of those. So I was going to ask if you've all heard of NICE, but Fiona's told you about NICE, so just I'm assuming it's fairly well known even to people from other countries. It was set up in 1999, and this slide summarises it all, a short history of NICE products. I want to move on fairly rapidly to the top right-hand part of the slide, NHS Evidence, but it's quite interesting sometimes to see the way the organisation's grown and developed. The best known piece of NICE is the bit at the very bottom left here. I don't know if you can read it. That's technology appraisals. And that's what NICE tends to be most well known for, and that's what tends to be the most controversial. It's been in the news quite a lot over the weekend, and indeed yesterday and today, with respect to value-based pricing. But that's not my agenda for today. If you want to talk to me about value-based pricing, perhaps after the meeting. What I do want to talk about is NHS Evidence. But the purpose of showing this slide was to highlight that there is a range of products within NICE. So when I get to the new developments, some of those are very much to take into account the fact that we have quite a plethora of products. So the history, NHS Evidence was launched as a service in April last year. And it had quite a big ask, really. It had to be an evidence-based portal to provide information to a large audience, a whole range of people that work in the health service, from pharmacists to medics, nurses, managers, commissioners, those working in social care. So very broad audience with a whole range of different requirements. And we had to provide a single portal for all of those people working in different ways. So to kick off the process and to determine how did we aim to do that, we initially ran a user survey to get some feedback on what people wanted and what they were using at that point. And we also looked internationally. Sadly, I didn't get to do a world tour at that point, but we reviewed a whole range of international portals to look at how they were working and what we might take forward ourselves. And those international links are still important because it's a challenging world to work in. And we are this autumn arranging an international meeting for early next year so that we can continue to share experience and learn from each other. So when we launched NHS Evidence, it looked largely like this. And this appearance was based on the feedback from audiences, which was that most people were using Google to find things, and our experience is still very much that people go to Google for a quick answer. So the overriding feedback was that we needed to provide a simple search. It's got to be simple, it's got to be easy to use, but it's got to be better than Google. Now that's a bit of a big ask, isn't it, to be better than Google? The obvious thing is in terms of selecting the sources that you might draw upon within a simple search. We also provide an advanced database search, which was originally developed for the National Electronic Library of Medicine in the UK, which we've adopted. And that provides you with access to databases like Medline and Embase, key obvious databases. And I'm not going to talk much about that aspect of NHS Evidence. We set up an accreditation programme, and again I'll tell you a bit more about that. That was very much in response to the notion that if you're going to provide a whole range of information for a lot of different audiences, how do you distinguish what's the best out of all that information? And a formal accreditation programme seemed the best way to take that forward. Users also said, as well as a simple search to help us find things, we want to be able to browse a topic if we don't know much about it. So we at the start built on, again, a feature within the National Library for Health. And we added a personalisation feature so that if you are a particular specialist, you will be provided with information for your specialist area. So those are the key features that we identified following the initial user research. We provide access through that simple Google-like search to a whole range of different resources, and we're constantly adding to those resources. We began focusing on UK resources simply because that was our principal audience, but increasing feedback indicates that we need to broaden that much more and draw upon international sources. I talked at the very beginning about, well, what are the methods and processes that we need to use? And within those methods, we're looking at setting clear criteria for international resources as we have for UK sources. And next year, there'll be an opportunity to look at the manual that we use to develop NHS Evidence. We're going to consult on it for the standard 3-month consultation period, and very keen to get feedback. So if you have the time and the inclination next year to look at how we're doing all this, very much welcome your feedback. Some very well-known resources on here that you'd expect to see: Cochrane Library, the Map of Medicine. Those are things that you can find through NHS Evidence. So, from a simple search, you might have a typical question like this, I guess. If you've got uncomplicated cystitis, how many days do you need to be treated with an antibiotic? I say it's a simple question, but when I've asked it in conferences where there's interactive voting, you'd be surprised how many people don't get it right, so perhaps an important question. The purpose of showing that is to illustrate that if you want to do a search on NHS Evidence, it's fairly straightforward. It's simple. You don't need any particular training. If you can see at the top there, prescribing antibiotics for cystitis. It will come up with a list of search returns. And in addition to the key task of identifying what are the resources that you draw upon, this part, which is the ranking of those search returns, is one of the most difficult things to get right. We have a ranking and relevancy strategy that we constantly refine. And getting the most relevant search return at the top is obviously of key importance. But it's not always that straightforward. There's a whole range of different types of products that people might like to see. So there are also filters on the left if you want to refine it a bit more yourself, if you wanted to look, say, for specifically systematic reviews. But this is an ongoing challenge to get this right. We're not Google, clearly. Google has 20 years of experience, so we're relying a lot on identifying the key resources initially and ordering them by what you might recognize as the evidence triangle, with primary research at the bottom, moving into summarized research, guidelines, and the initial search return would be at the top of that pyramid. I'm pointing it at the wrong place. There we go. I mentioned accredited sources. This was something we felt was very important early on, based on the fact there's a lot of sources there. We began by looking at accrediting guideline products or guidance, things that are summarized research evidence, summarized into recommendations for the users, with the aim of helping people identify what the best sources are, but also to drive up the quality of that evidence as well. And that has been something that we've seen over the past year quite starkly, in so much as organisations have taken stock of what we're asking them to be achieving prior to applying for accreditation. They're going away and looking at their processes and methods and making sure that they are working to these standards before they put in an application for accreditation. The criteria that we use aren't ones that we developed ourselves, which made the whole process somewhat more straightforward. We didn't have to start from scratch. There's been an international group, an AGREE consortium, that's over the past 10-15 years looked at what makes a good guideline, and we adopted those criteria in the process for accrediting guidance. We use an independent advisory committee, and they assess the submissions from organisations that tend to be professional bodies. The Royal College of Physicians, for instance, put in an application for its stroke guideline, and we assess the methods that we used against the criteria and award an accreditation mark. We are, of course, looking at whether we should expand this accreditation scheme. It covers products that are core guidance, but there's a lot of interest and a lot of requests for us to accredit things like commissioning guides, educational tools, systematic reviews, and we're looking seriously at whether or not we can carry that forward. Depends partly on resources, but also on the criteria that we can use. These criteria for guidelines, as I said, were already in place, which made the task more straightforward. It's also something that's generating interest internationally, and we have had interest from international guidance producers and have taken a decision that we will put them through the process. We do have to charge a fee for international guidance producers, if anybody is here and interested. NHS Evidence is funded through government money, through taxpayers, through the taxpayer purse. So we didn't feel it was justified to accredit international resources without charging a fee. So that's the boilerplate, as it's called, that denotes an accreditation from NHS Evidence. And NICE did put its own products through this process. You might be interested to know. Just felt we should do that first. And when you do a search on NHS Evidence, anything that's been awarded the accreditation mark is highlighted with the mark on the search return, but increasingly it's also being displayed elsewhere. This slide is to show you something that's going to change, but it has been a feature of NHS Evidence since we launched it last year. These are called specialist collections, specialist pages in different topics, and this one is the cancer page. And these allow you to do the browsing that I described, that I said users wanted to do. And they've served us very well. But as technology is developing, we can provide a browse function in a somewhat different way. So towards the end, I'll show you some of the screenshots from the new way that we'll be doing that from next year. So just briefly, before I move into the future, the challenge that I'm sure you've been discussing at various points of this meeting is this bit, actually getting the evidence used and changing practice. And this is a slide I've used a lot over the years because back in 2003, I think it was, NICE set up an implementation program that was designed to ensure NICE guidance was put into practice. So a specific program focused on NICE guidance. And we set it up with 4 key strands to make sure guidance was disseminated effectively, to motivate people to use it, looking at things like educational levers, looking at funding mechanisms. We provide practical support, help for how you cost guidance before you put it into practice. And we have an evaluation program. So the reason for introducing that is to say that we've recently taken a decision within NICE to bring that implementation support function within the umbrella of NHS Evidence. And that gives us the opportunity to support not just NICE guidance into practice, but to support the use of evidence as a whole through NHS Evidence. So it's a new part of NICE, it's bringing two together, and I think will give us a stronger team in future and opportunities to network much more at a local level through a field team that we have dotted around the country. 7 people covering the country, so they have to travel a fair bit, but it gives us the opportunity to engage with hospitals, GPs, etc. at a local level and to understand their needs and their challenges, which is particularly important at the moment with the changes going on in the health service. So that's background. Some of the new things to talk about relate to QUIP. A lot of you will know what QUIP means. In case you don't, it's quality, innovation, productivity and prevention, and a big sort of drive within the health service to fundamentally maintain quality of services while reducing costs. I'm going to talk to you about the new developments in NHS Evidence around search and browse and show you something that we're calling at the moment pathways, but I've had feedback that says pathways might not be the right name, so if you feel free to suggest some better names before it gets too late. So, quality and productivity, a big drive across the health service with the requirement to save billions of pounds over the next few years. It's something NICE has always been sensitive to because NICE makes recommendations that sometimes drive more investment, particularly in use of new drugs. Sometimes they don't. Sometimes we make recommendations to stop doing things. But a few years ago, we were asked to specifically focus on areas where we could say stop doing things. So we introduced a program to trawl through the evidence to try and identify areas where there was ineffective practice. At one point we thought we'd call this program the RIP program, the Reducing Ineffective Practice program, but there were those that thought it might not be the best acronym to use, although it has its merits. So the RIP program didn't turn up with many new topics, but we produced some guidance on grommets. We also trawled through our database of recommendations from all the guidelines, technology appraisals, etc. that we've produced, and we came up with about 500 recommendations that said, don't do these things, and it will save money, clearly, if you don't. We produced cost impact reports that always identify where there are savings associated with guidance. And recently, in fact, the week before last, we've published on the NICE website a database of referral criteria to help people manage referrals appropriately into secondary care. We're doing some work specifically to assess examples from the health service as to where they have had evidence-based projects to reduce costs and improve quality, and we've been trawling the Cochrane database. I'm going to talk a little bit about some of those, but the overall message perhaps to take from this slide is that NICE has done an awful lot to trawl through as much evidence as we possibly can to look for things where there is clearly evidence to say we shouldn't be doing these things. Quite often there isn't evidence that something works, and we've specifically been looking for evidence, positive evidence that something isn't worth doing. Right, so I shall highlight some of those. I'm going to highlight some of the cost impact work, how we assess the QIP submissions from the health service, and then how we display that on NHS Evidence. When we look at NICE guidance, we always cost it, and not infrequently they're associated with savings. You'll see some examples on this slide. For instance, if you reduce referrals for a urinary tract infection, you might save at a national level £2 million. The big question that people always ask is, well, are these genuine cash-releasing savings, the dark green dollars, as I think economists would describe them, or are they productivity savings, or other types of savings like sort of reduced use of beds that can be quite difficult in terms of releasing cash, and at the moment it's cash that the NHS needs to find. Those cost-saving examples are available on the NICE website and also through NHS Evidence. Now, as part of all this QIP work, we also are looking at examples that are submitted to us from across the health service, looking at whether they are genuinely evidence-based. And there's a lot of evidence that we need to assess in doing this. And not many of them meet the thresholds that I'm going to describe. So we look at whether the examples have an evidence base to show that they actually save money. The more money they save, the better. We look at whether they are improving quality. There might be a bit of trade-off there. If you've got an initiative that is shown to improve quality significantly, you might be prepared to trade that against not much in the way of savings. But if you don't meet either of those, we exclude them. We then go on to look at the evidence behind it, because we're looking for more than, well, that was simply a good idea. There needs to be a proven evidence base behind the suggestion. And then we also look at ease of implementation. There's quite a pressure at the moment to look for cost savings. So examples where it takes 5 years to implement are probably not going to be the most popular. All of this information is available on NHS Evidence on a page that at the moment doesn't look very inspiring, but it will be modified next year in line with the other changes I'll come on to in a moment. But it is covering a whole lot of information. It's covering all that QIP evidence that I've indicated. It recommends some of them, and it highlights examples from the Cochrane library. We've worked very closely with Cochrane, and they've given us submissions to assess to determine whether they really might save money across the health service. So they've provided an evidence base, and we've done a costing assessment. So that's QIP. Now moving on to some of the changes that you'll see next year in NHS Evidence. The new home screen. The obvious thing is the eyes got bigger. I'm told this is very popular with users. I'm not quite sure why a big eye is more popular than a small one, but that's fine. There are some boxes over here that will have more than text in, but the idea is that you'll be able to go from that home page directly into a particular area of interest, which might, say, be public health. We've modified the way that this, the search, the typing in of the search term works. I'm told by technical colleagues this is called IntelliSense. So you type in and it suggests what you might want to look at. You can also at that point, if you follow the topic button, go into suggested clinical topics if you want to browse those topics. They might be listed like that or in more detail if you want by A to Z. To give you an example, if for instance you went into the epilepsy page, key features that you'll notice here are a brief introduction to what epilepsy is. Now clearly a lot of professionals won't need to see that, but the general feedback that we've had is that that is useful. It might not be there automatically, it might be something you could ask for if you want that additional information. And then over on the right, you can see these pieces here, which I gather are called accordions. And the advantage of those accordion buttons is that you can bring in a lot of information with depth alongside the search returns that continue to be displayed down the bottom. So for instance, if you click initially on the guidance button, this is displaying a link through to NICE guidance. And a little pathway that I'll talk about in a moment. We've had feedback that NICE guidance is too difficult to find in the current system. So this will highlight NICE guidance, but there'll also be an opportunity to show guidance from other sources. NICE hasn't covered everything, and we never will. But we do need to therefore determine when it isn't NICE products, what's the next best? Will it be the accredited products? What else might we suitably display at that level? We also have a button that says medicines information. Again, the user feedback indicates that you might want to very quickly flip between one and the other. And here it demonstrates some links with the BNF, and we've been working closely with the BNF team in order to ensure that this information can be displayed here. The advantage of having those accordion tabs is that a lot of information can be displayed at that level. And another piece of development work for the future is to provide links to ongoing trials. Again, clinicians will want to see not just what the evidence is now, but what the ongoing trials are. Now, this is a slightly bigger picture of the pathway that I had up earlier. This is important for NICE for a number of reasons, but it's not the map of medicine. I need to say that because people always say, well, what's the difference between that and the map of medicine? The key reason that NICE is presenting information like this goes back to the slide that I showed you at the beginning, the slide that had lots and lots and lots of different NICE products. It's got to the point where it's quite difficult for staff within NICE to identify all the various pieces of guidance that might relate to, say, bowel cancer, whatever the topic might be. So the idea of a pathway for NICE is to be able to link those all together. So the high-level pathway, you can drill down into the detail that NICE has produced and link through to the underpinning evidence. It becomes increasingly important as we do other things as well, like quality standards. And I do want to just mention those too, because within a whole pathway of care, this presentation will enable us to show where there are quality standards. So, just summarising, these pathways are going to bring together all the related guidance and make it easier for everyone to access, but particularly perhaps with commissioners in mind in the light of the quality standards. and we are aiming to launch this presentation next year, probably in May. Now, some people will be aware that there are now also things called quality standards. And a quality standard is something NICE has been asked to produce that is pretty small, so it's not a guideline. It's just a sort of summarised set of the most important areas within a pathway of care. So they have to act as markers of high quality care in that topic area. They are evidence-based, and very importantly, we need to produce them collaboratively. I talked a bit earlier about the evidence triangle. And the evidence triangle, very distilled down, but here it helps indicate where quality standards fit. If you've got your research and audit evidence at the bottom, then you've got guidance based on that. Quality standards are, if you like, the very tip of that iceberg, and will be important in the future in terms of driving up quality of care. And the plans are that we will have 150 quality standards. Each one of those will have 5 to 10 statements in them. So overall, quite a lot of information. We've published the 4 pilot topics on the left, and we will produce quality standards in those topic areas on the right this year. But very quickly, we need to build up this library of topics. And the reason for that is that they are an important component of what the new government is linking to their NHS Outcomes Framework. And if anyone has read any of the recent documents, you'll see this sort of relationship, quality standards driving indicators that will be assessed in the NHS Outcomes Framework. That's why it's important that we produce 150 fairly quickly to inform this. Going back to my pathway presentation, we will be able to map into the pathway where these quality standards exist at the appropriate points, and then link to the measurable indicators. NICE won't be developing measurable indicators, but we will be working with the NHS Information Centre to ensure that they are things that can be routinely measured as far as possible. So just a few more slides on what the future might hold. Quite a changing time in the English NHS at the moment. We've had a number of white papers that were published over the summer, and 2 more a couple of weeks ago, Greater Choice and Control and an Information Revolution. And there's some interesting concepts and ideas in those white papers that might be relevant to NICE in the future. So we are going to talk to our key stakeholders and work through what might be an appropriate response from NICE. Again, they mention quality standards, so I won't rehearse that again. They also talk about treatments of unproven value, which is an area, as I've indicated, we've looked at in the past. Decision aids are raised in those documents, and decision aids are a potentially important tool that we would need to reflect within NHS evidence and potentially support the development of through the work that NICE does in assessing the evidence. Patient information is questioned within these documents, and potentially something that we could support in future. I didn't mention when I was talking through NHS evidence, and I probably should have done, but we don't write information for patients within NHS evidence. It was designed as a portal for professionals. But because it's largely openly available, we know that quite a lot of patient groups do use it and they like it. Professionals have said, can you provide us with access to patient information as well? And we do, but we restrict it to patient information that's been accredited by the Department of Health. They have a system called the Information Standard. So that's what we currently provide at the moment. The white papers also mention pathways and they mention accreditation. So quite a lot of overlap with what we do at the moment. And my penultimate slide is just to rehearse perhaps the overall package within NICE and some of the way that the future, some of the future direction that we need to consider. We produce guidance, that's the biggest box. We'll be producing quality standards. We provide implementation support for those things. Research recommendations are identified across those products and wherever possible fed into the research agenda. We provide access to evidence and accredited guidance from other sources, and some of those we fund. For instance, we fund access to Cochrane across the NHS. The QUIP work I've described, and one thing that I haven't, and I don't know whether any of you will have picked it up recently, but the National Prescribing Centre is going to be transferred to NICE from April next year. We've worked with the National Prescribing Centre quite a lot over the years, and they do very relevant stuff. So it's great to have the opportunity to work more closely with them in the future. Access to all of that is through NHS Evidence, and we've got a number of support networks to help us to engage with the key audiences. Now, audiences for NHS Evidence have always been public health, healthcare and social care, but another change for NICE in the future is a social care remit that will relate not just to NHS Evidence, but to guidance and quality standards. It hasn't yet been clarified exactly what NICE's role will be in relation to social care, but clearly it will involve the development of quality standards as a minimum. So quite a big picture for the future, very much an organisation driven by evidence and evidence-based products. So I think I've done enough talking. So at this point it would be great to have some of your thoughts and feedback on, not on NICE, but specifically on NHS Evidence as a product, what we might need to do in the future, and how we support implementing change. So thank you very much. Can you come and sit there?
I just wanted to start with a question for I have. How effective is NICE, do you think, about getting evidence into practice, and how do you assess that? How should we assess that?
It was one of the strands of the implementation strategy. You probably won't remember, but the bottom bit was evaluation, evaluating uptake of the recommendations, because it's a key part, isn't it? There's no point carrying on churning it out if you haven't got some of that feedback loop. And feedback's sort of soft stuff, what do people like, what don't they like, but have the recommendations actually been followed is an important question. And to answer that question, we have done two main things over the years. One is to analyse routine data, predominantly in conjunction with the NHS Information Centre. It's quite easy to do around new drugs, anything where there's a sort of drug and a single use. And I didn't show any today, but I've got some quite powerful graphs, if you like. They show the use of a drug being fairly low, nice guidance coming out, and the usage going up. So you can show that sort of impact. That sort of analysis is quite difficult to determine, though, whether the right people are getting that drug, whether they're getting it for the right length of time. It just gives you an indication of impact. We also, the other plank, have worked with organisations that have a role for looking at feedback, so national audits, for instance, and the Healthcare Commission, now the Care Quality Commission. We've worked with them so that when they are doing national surveys, they will build in NICE recommendations. So that we don't have a budget to do that ourselves, so that's as far as we can go. And in terms of success, it's not 100%, I don't know how you'd assess an overall figure, but on balance, in most areas, you see change taking place over a number of years as you'd expect. You get some resistance in some areas, and I have to say it's largely individual clinicians when you get resistance. That's certainly evidence-based, but generally evidence to show an impact.
Okay, thank you very much. Questions? There's one here. Any other questions while we're getting the mic? And in the same row, and one right at the back. So there's three there.
Do you have any idea of how far NICE has been successful in promoting or implementing the pharmacological products which are not on active promotion by the industry?
Do you have any idea of how successful NICE has been in tackling unethical promotion by industry? Is that right? Was it unethical or?
What I mean is that industry is actively promoting the pharmacological interventions. So what is the evidence that NICE has been successful in promoting those medicines which are not on active promotion? I'm just thinking of, say, for example, clozapine, which is one of the most effective products in psychiatry, not being actively promoted at the moment by the industry.
So it's a question of how to actively promote effective treatments that are not promoted by industry.
Yeah. Our approach has been uniform in terms of assessing where we need to provide implementation support. We've took an approach that we wouldn't work directly with the industry around any promotion because we need to keep arm's length. But it's probably fair to say where we've said yes and the industry gets behind the product, it might be adopted more quickly. We do, though, look for barriers to uptake. So where we think a product isn't being adopted as rapidly as it should be, we will plan some implementation initiatives in response to that. But it remains a challenge that some products have more support from the industry than others. And there are other graphs that show not just the sort of increase in use of a drug when we've recommended it, but also the other way, it will go down. So there is a lot of sensitivity between what NICE says and what the industry thinks.
Okay, thank you. And along the row there.
Thank you. I wonder how, if I look back to my own career, these are changes that go very rapidly. And if I look at education, how is the workforce, the new workforce, prepared to use these instruments? How does it affect the medical schools and the curriculum? Is there any link here? I'm from the Netherlands, and there is no link whatsoever in this respect for decision support or the medical decision support or tools. There is some aspects in the Netherlands, but very few in the curriculum. So I wonder how it's here.
Okay, did you get that?
I think
so it's really saying what about medical schools? Is there any education and does NICE reach out to medical schools? The question was from the Netherlands where that doesn't happen. Doesn't happen.
I mean, NICE, with NICE's own products, hasn't done much over the years, I have to be honest. We haven't done much in relation to medical schools, but we have done with NHS Evidence, partly because we had links with librarian networks who were based in medical schools and suggested that it might be helpful. So we have been, through the various networks that we've got, engaging with all the medical schools in England and providing them with information about NHS Evidence, helping them to embed it in whatever IT systems they use, offering to provide some training. Some of us go out and talk to medical students about the use of evidence in general, about the use of NICE and NHS Evidence. We also had something called a student champion scheme that one of the NICE fellows initiated, identifying some medical students who'd effectively champion the use of evidence, and that's being evaluated informally. It seems to be quite successful. You get some student champions, they support the use of evidence, seems to be working well. And we've also, taking part in a pilot piece of work at Leeds Medical School where they are funding, and I thought medical schools didn't have much money, but they're funding iPhones for their medical students. And so we've taken part in that by ensuring we've got NHS evidence on the iPhone, so we'll see how well that goes down.
One of the things we have found is feedback to the journal is the lack in the UK or the weakening of prescribing, teaching how to prescribe. And the clinical pharmacology has been a topic that has tended to lose resource in the UK. I don't know if it's the same as in the Netherlands. So certainly the BMJ and publishing group, we're trying to support more evidence-based prescribing teaching in medical schools, but it's a tough one. There's a question at the back, and any more questions around? And then one here, please. Ben.
Thanks. It's not the most important thing in the world, but how many visitors do you get? And also, since with a website it's very easy to track how people move through and when they come back, what have you learnt about how people use the resources and whether they are repeat visitors?
I tried to ask you to remember lots of data that's routinely published in the board report, and I can't remember the numbers. In terms of searches, which is a figure that for whatever reason is in my mind more than the others, it's about 1.5 million searches a month. And we are tracking that. We're tracking it compared with this time last year.
And that's UK and international. It's available international, UK
yeah.
and international.
That figure, I think, is an international figure, and I think, from memory, about 10% of the use is non-UK, but that's from memory, which is significantly lower than the NICE website, where about 50% of use of NICE website is international, which is interesting.
Thank you. Question here.
Ruth Taylor, GP in London. What do you think the implications are for the government's new edict that NICE will no longer be able to advise against NHS funding for certain drugs and presumably appliances based on the evidence available?
Gillian thought we might get this question.
I mean, there's a short answer and a very long involved discussion we could have, and probably best to stick to the short one at this point. The value-based pricing scheme that the government's talking about won't be introduced until 2014. So there's quite a period to go until then. And the reason it's 2014 is because that's when our pricing scheme for new drugs, the PPRS, Prescriptions Pricing Regulatory Scheme, gets renegotiated with the pharmaceutical industry, so it can't come in till then. There needs to be some work done around the methodology for how that value-based pricing works. I mean, in a nutshell, value-based pricing means setting the price for the drug depending on how well it works, how much value do we attach to it. And the methodology for doing that is quite complicated. There are examples in various different countries and different ways of doing it. And the way we do it would need to be negotiated with the pharmaceutical industry. We've had very positive messages from various ministers over the past month or so that NICE would continue to play a key role within that. So that's positive, that's reassuring. What exactly that role is and how the value-based pricing will work, I'm not in a position to say at this point. I do think, though, it's important that we remember that there's that 2014 timeline and that we need to have a mechanism in place up until then so that users in the NHS, commissioners, are aware of what's happening before then. And as far as we understand it, we continue to produce technology appraisals until the new system is in place.
And I think that timeline is important, certainly speaking for the BMJ, but for the community at large, it provides a window for some debate, exactly as Gillian is saying about exactly what the methodology might be, whether it's at the point of licensing of a drug or whether it's at a subsequent point when we've got some actual post-marketing surveillance data about the drug's performance. There's a range of issues which I think we absolutely have to explore. And I mean, forgive me, Gillian, but the sense of about what NICE's role, I'm speaking for myself, I'm not clear why NICE's role couldn't carry on as it is with a value-based pricing model, as opposed to, I know you would have read the article in The Guardian, which suggested that NICE's role would be in some way diminished. So, obviously those are all things that I'm sure the journal will debate and other debates will take place, and we've got a period of precious time to try to get the model right. I mean, if anyone in the audience is coming from a country where there is any form of value-based pricing that is functioning, or a system which you think we ought to learn from, we'd really like to hear from you. So, anyway, there was another question here, one. And any other hands being raised? Anyone there? Thank you.
Jan Oster, I'm a GP in Brighton. You, I think, a little bit answered my question in the way of the future of NICE and NHS and evidence. With the pressure on resources and with the commissioning groups coming in and the reformation of that, I think that this service is going to be absolutely essential to these groups. And can you tell us what you think about the future funding and the consolidation or expansion of the evidence base you work on, and can we feel that it's going to be there to support the new commissioning services?
Well, can I just ask, when you said future funding, did you mean funding for NICE?
Funding for you, yes,
Yeah.
For this service, which I think is going to be absolutely essential for us, on which we will lean increasingly in order to be able to do the job.
Well, I mean, thanks for that supportive comment. I'd agree with that. We, like all of the NHS, are being pushed to make efficiency savings. So I don't think there'll be any way or any escape from that. But the support remains that these functions will be key to the new way that the NHS will work. I talked about the quality standards, the evidence base, the indicators. There's another plank of that which I didn't mention, but there is to be a commissioning guide for each quality standard area, which NICE could support or inform, however it plays out. So there are a lot of reasons why it is an important service moving forward. And hopefully the funding will be secure. We're one of the few pieces of the NHS at the moment that has been allowed to recruit significant numbers of posts, which I think is a reflection of the confidence and support in us moving forward.
Thank you. And there was a question here. Thanks.
Terry Harrison from Melbourne, Australia, soon to be living in and working in London. It's interesting to see how the information landscape and the evidence landscape has changed over the last 10 years, and there's been a proliferation of evidence sources which people can search, etc. But there's also a push towards centralisation, which I think is an interesting dynamic. Now, I like to be able to ask myself the question, where are we going to be in 10 or 15 years from now? And I know a lot of clinicians I've been working with will often say things like, I don't want to search anymore. I want the answers coming direct to me. In other words, we do not want search engines. I would like to predict in 10 or 15 years' time there will be no search engines. All the work will be done automatically and go directly to the point of care. Now, that's a huge change, a quantum leap, but I would like to think that the NHS Evidence and other organisations are looking in that direction and working towards it. What's your comments, please?
So how quickly, Gillian, can we imagine NHS Evidence incorporated into the actual work pathway for doctors and nurses?
You're right that that's a really key thing to do, because as those systems are used more and more, that's where people using this system over here, that's where they want to find the answers, sort of part and parcel of whatever it is, product that's being used. So we have approved this year a third-party syndication strategy to give it its title, but that's very much about us now actively engaging with third-party providers of IT systems where we can embed the most useful evidence base. It doesn't take away from the jobs that we're doing here, because if you're going to do that task, you need to be clear that you're putting the right evidence in. That might be information that's come from NICE, or where there's no NICE guidance, another accredited source. It again underpins the need to have an accredited source of information when NICE won't cover everything. But having gone through that process, I think we are now well placed to be able to take that forward. NICE set up, and you're also right to look 10 years ahead, because if I look 10 years back, when NICE began, we weren't thinking digitally at all. It was paper products, and it's taken us quite a while to re-engineer those paper products into a digital format that will be, that have the potential to be embedded in other people's systems. So we are actively doing that. We need to continue to engage with users to get the feedback around what's required. When we started out 2 years ago, people said quite firmly, don't filter the evidence base. We want access to a comprehensive evidence base, so if we want to see X, Y, and Z, it's all there, and you haven't just filtered it out. And the chances are we still need to do that, but the other as well.
Any other questions? There's one at the back there. And while the microphone's just going, we're doing this with BMJ Evidence, the Evidence Centre, which I think some of you heard about earlier, of actually trying to incorporate it into systems. It's a complicated process. We're working with Cerner and other IT systems, and I'm absolutely sure you're right that the only real way to get this evidence change in practice is to have the things coming up at the point of care, and we're working hard to do that at the BMJ as well. So, thank you at the back.
I've got a quick question about in the last few years, we've seen NICE guidance trumped by a lot of patient pressure and patient groups demanding treatment that NICE has not felt was cost effective. Moving forward, when we've seen the white paper coming into force with GP commissioning, empowered patients, no decision about me without me, do you see that there's going to be more conflict of that type moving forward between patient groups and the empowered patients and NICE guidelines?
You may well be right. You may well be right. I mean, and you're also right to point out that it's never been a conflict-free area, because the decisions that NICE has taken have been difficult decisions. Difficult whenever there's a question of cost coming into it. It's not straightforward. And there's differences of views between the patient groups, the professional groups, the producers, the drug companies, so it's always controversial, and you may well be right that it will become more of an issue as we move forward. The threshold that we've used to take those decisions, a threshold range, we have re-evaluated regularly, taking patient views into account alongside everyone else to make sure it's not too high, not too low. But it's inevitably a controversial area. And I don't think it will be any less controversial, whoever took those decisions.
Gillian, that's where we must come to an end. Thank you. Controversy suggests you're fighting the good fight, and long may that continue. Thank you very much for a very good conversation.